A 56-year-old man presents with a progressive decrease in stool caliber, severe abdominal fullness, and recent weight loss. I am showing you an upright abdominal radiograph and an axial contrast-enhanced CT performed with rectal contrast. Describe the findings.
Okay, I see it. The upright radiograph demonstrates marked diffuse large bowel dilatation with multiple prominent air fluid levels, which is highly suspicious for a mechanical large bowel obstruction. The subsequent CT reveals dense rectal contrast flowing retrogradely to the level of the sigmoid colon, where it meets an abrupt cutoff.
What is the exact cause of this abrupt cutoff in the sigmoid colon?
Well, the cutoff is caused by a focal, highly irregular, near-obstructing, and circumferentially enhancing colonic mass. The descending colon immediately proximal to this mass is severely dilated.
What is the primary diagnosis?
The definitive diagnosis is a primary colonic adenocarcinoma located in the sigmoid colon, presenting acutely with a high-grade large bowel obstruction.
If a patient presents with a very focal area of severe colonic narrowing, how can CT help differentiate an obstructing colonic carcinoma from severe stricturing diverticulitis?
While significant overlap exists, a colonic carcinoma typically presents as a discrete, asymmetric soft tissue mass with abrupt, shouldered margins, often accompanied by regional malignant lymphadenopathy.
And how would stricturing diverticulitis typically appear?
Diverticulitis typically shows a much longer segment of symmetric wall thickening, the presence of extensive diverticulosis, and marked surrounding inflammatory fat stranding without discrete lymphadenopathy.
Why do left-sided colon cancers frequently present with obstruction or changes in stool caliber, whereas right-sided cancers classically present with occult anemia?
If we look closely, the left colon has a much narrower anatomical lumen, and the stool is highly solid, meaning even a moderate-sized mass can rapidly cause mechanical obstruction. In the right colon, the lumen is very capacious and the stool is liquid.
How does that affect the presentation of right-sided masses?
Because of the large capacity, right-sided masses can grow silently to a massive size, chronically oozing blood and causing profound anemia long before they ever physically obstruct the bowel.
How would you manage this patient as a radiologist right now?
So, I would immediately alert the surgical team regarding the impending complete large bowel obstruction. Because the obstruction prevents a full standard colonoscopic evaluation, I must meticulously evaluate the rest of the abdomen, pelvis, and chest for metastatic disease.
What would be your recommendation at the GI-MDT for this patient?
I would present the case at the GI-MDT to rapidly coordinate care, recommending either an urgent surgical resection or, more likely, a temporizing endoscopic stenting procedure to decompress the colon prior to definitive oncologic therapy.